Thank you, Jorge, for the introduction. Can you see my slides?
Yes.
Okay. So although I'm presenting today, actually, I'm presenting on behalf of a whole team of clinicians who were working with a client whose case study we will talk about today. So I would like to acknowledge Hassan's, David, Sayoris, and Indira's work with this client. So objectives of my presentation are to describe the impact of chronic trauma on sleep, and then to illustrate START's biopsychosocial model of care in addressing refugee trauma using a case study. We will look then at the effectiveness of neurofeedback in addressing psychophysiological effects of chronic trauma, and we will focus on brain dysregulation, arousal, and sleep difficulties. Then we will describe the importance of behavioral activation program in improving sleep and overall well-being. At the end, we will explain how interventions focused on addressing psychophysiological effects of chronic trauma can prepare the client for trauma reprocessing. Looking at 100 clients who were referred to START's Neurofeedback Program between 2016 and 2020, and we had 100 clients in this cohort. These are 6 main disorders, or looking at DSM-5, what are the main clinical presentations of our clients? We can say that complex PTSD, chronic PTSD with dissociative symptoms, major depressive disorder, somatic symptoms disorder with predominant pain, persistent complex derailment disorder, and sleep disorders are the most frequently seen. Zooming into sleep disorder, we can think about sleep disorder as an expression of dysregulated nervous system, and I will explain how we were addressing through different interventions our clients' sleep. Looking at 100 clients who assessed our treatment, 68% of them reported moderate to severe sleep difficulties falling asleep and maintaining sleep. But 82% said that they had moderate to severe nightmares. Other sleep disorders that we've seen frequently are sleep apnea, circadian rhythm, sleep-wake disorder. One that we are talking about today, who gave us his permission to talk about his case, was 56 years old, male, from Afghanistan. At the time, when he arrived in Australia in 2003, but he wasn't seen by START until 2011. He had a history of war and refugee trauma. He witnessed killing, destruction. He was exposed to grenade and bomb attacks, suffered lack of shelter and food, traumatic flee from Afghanistan, then asylum in Pakistan, and of course, resettlement difficulties when he arrived to Australia. He arrived with his 2 children and his wife. His main symptoms at intake were insomnia with repetitive nightmares and intrusions. He also had increased arousal and anxiety and panic attacks. He had mood dysregulation. He would get quite angry, and he was also quite depressed. And he had paranoid ideation. He had chronic headaches and chronically feeling dizzy. But on top of that, he had temporal lobe epilepsy. And he reported 4 to 5 seizures, quite severe seizures per week at the time when he was referred for neurofeedback. At STARTS, to address all these complexities of different presentations, and our clients, each one of them had something specific, unique, that we don't see in research literature, that then we as clinicians are trying to address. So model that we use at STARTS is called biopsychosocial model of care. On biological level, we look for interventions that can help reverse the effect of trauma on brain, such as biofeedback, neurofeedback, yoga, mindfulness, and other interventions. On psychological level, we look for interventions to help people process trauma, make sense of their world again, rebuild their identity, rebuild secure attachment, regain their sense of self and self-esteem, capacity to trust themselves and others. And for that, we use different types of psychotherapy, work with parents, when we work with children, work with carers, also different group interventions. On social level, we look for interventions to develop social support systems, increase work and school readiness, reduce isolation, promote positive social relationships. And we have different school programs, capoeira classes, different social groups, community events. So all of that together in working, even when we work individually with the client, we always take all these three domains into account. We're looking to enhance strength and resilience and address effects of trauma. For this client, we used a lot of different interventions over several years. And I will now outline some of them. Looking at the history of our clients, and we will call him Mr. Alam, treatment that starts. He was referred in November 2011, and initially he went through 54 counseling sessions. Then he was referred for neurofeedback. We had additional 60 sessions of neurofeedback. He experienced loss of some of his relatives in Afghanistan, and then he had additional grief therapy sessions. And then another 20 sessions of neurofeedback just to help a little bit more with his nervous system. Then he was referred for behavioral activation and nutritional program. And at the end, he went through EMDR or trauma reprocessing sessions. He was discharged from STARTS in March 2019. And when I called him a couple of days ago, he said he's stable, he's fine, he's okay. Through all this time, while he was going through different interventions, he was also involved in a group. It's a social group of male people from Afghanistan. He was taking medication for epilepsy and also for sleep. And his wife, who was also his carer, was also receiving support from STARTS. Initially, he received supportive counseling, and Hassan, my colleague, was working with him. He helped to build trust with the service and also to build that sense of safety externally and internally. He made a lot of assessments and referrals to internal and external services, offered psychoeducation, active listening with respect, and was working a lot on stabilizing him through stabilizing his and improving his emotional regulation and symptom management. Part of the treatment was also grief counseling. Case management, advocacy are always part of our work. But with all of these interventions that they're geared towards stabilizing the client and to prepare him for trauma therapy, for trauma processing, he was unable to engage, even after almost 60 sessions, into trauma reprocessing, because as soon as he would start to talk about trauma, he would go into a seizure. For that reason, he was referred to Neurofeedback Program. Idea was to address his sleep, to address hyperarousal, to help with mood instability, and to see whether we can, through the reduction of arousal and stabilization of the nervous system, if we can, to a certain degree, also help with his temporal lobe epilepsy. Initially, we did brain assessment. That is a test that looks at normal and abnormal background rhythms, and also can inform us about different areas of the brain that are not functioning optimally. So we're looking at these brain maps that are telling us where in the brain are the main difficulties. And this can help us to plan our therapy interventions. Also, it can help with medication, deciding about medication, and to measure treatment outcomes. Our client, as we already knew, he had temporal epilepsy, so we could see some temporal lobe instabilities. Even that he was on Keppra, on medication, on anticonvulsants, he was still having really frequent and debilitating seizures. Another problem that we look at is frontal lobe difficulties that are actually also explaining some of his difficulties with regulating his affect, with his mood swings, with his anger that he couldn't address, and that he, also depression. And also what we could see from his EEG is that he had very fast activity frontocentrally that is seen in insomnia, resistant insomnia, and also is related to agitation and brain instability. So we applied neurofeedback. We used neurofeedback to address brain difficulties. Neurofeedback is training brain to produce brain waves that are more regular and that are producing more stable brainwave patterns, so that it can strengthen also neural networks that were less frequently used for those who were exposed to severe trauma. And that means to produce more stable, better regulated mood, and also to help client to move away from trauma-related symptoms such as severe agitation and insomnia on one end, on the other end, dissociative symptoms. So what is happening in neurofeedback is we put sensors on the skull, we measure brain waves, and then we present brain waves as visual images where the client can see when their brain is spontaneously moving into some middle range frequencies that are promoting improved mood, good focus, and calmness. And anytime when brain goes into a very fast mode, agitation, or very slow one, when clients are dissociating or feeling slight and disconnected, the rockets that are representing brain states would move faster than the middle rocket that represents well-regulated brain and mental states. So the aim is for this rocket middle rocket, green one, to fly faster, to actually promote brain waves that are better regulated. Based on assessment, we did neurofeedback treatment. We were focusing on temporal lobes where the seizures were, and also who are more related and connected with limbic system, the seat of our emotional brain, and also centrally, so that we can enhance his sleep and improve his mood. After 60 sessions, we could see decrease in beta spindles, in that very fast activity that is related to agitation, that indicated reduction in peripheral and central nervous system arousal. And also we had a decrease in frontal lobe alpha coherences that indicate increased inability to regulate affect. So idea was he was ready now for trauma processing. His nervous system was more prepared, so that, and actually he had decreasing seizures, so that he can tolerate trauma reprocessing. So from having 3 to 4 seizures per week, he had only 1 in 2 months. His neurologist reduced his anticonvulsant medication as well. He stopped having headaches and dizziness. His mood improved, and also his sleep was to a certain degree improved as well. Initially, he slept 3 to 4 hours, so he was able to sleep up to 6 hours, but he was still experiencing nightmares that would wake him up. He was then referred to our BodyFocused team before getting referred for trauma reprocessing. The idea was to improve his general well-being, to even further prepare him for trauma treatment. There is research that shows that physical activity and sleep are directly correlated. Meta-analysis of physical activity interventions showed that higher level of physical activity were associated with increased sleep duration, sleep efficiency, slow wave sleep, and subjective quality of sleep, as well as decreased sleep latency and wake after sleep onset. So there is good evidence that physical exercises could improve client sleeps. And in our body-focused intervention, David Perez was initially working with the client through his motivational interview and series of exercises that the client was prescribed, psychoeducation about the importance of changes in his daily habits, in also the sleep hygiene that needed to change. And also he was monitored, his progress in his treatment was monitored, and I will explain that a little bit further. He was also sent to our nutritionist, Sayori, because he had some issues with his diet. And when diet improves, we can also see some improvement in reduction in anxiety, improvement in mood and sleep as well. So Sayori explained to client what are Australian dietary guidelines, and she was talking about the importance of hydrating and certain types of food that are promoting well-being and that are better for client to use. But what she realized with this client is that he was drinking coffee and also Coca-Cola that is full of sugar. And we often see that with our clients who don't sleep well at night, that they need more energy. So they then drink energy drinks and a Coke and coffee. They have more sugar in their diet to stimulate their nervous system, but then they have difficulties falling asleep and maintaining their sleep, and they're feeling more anxious. So through this intervention, client was working on his diet and improved his diet, and that was then really well preparing him for the journey of the next part of his treatment. Meanwhile, what David was doing in behavioral activation sessions with his client was prescribing certain types of exercises that client would practice in the morning, and some also cardiovascular exercises that are really important for him. Cardiovascular exercises were practiced in the morning, and then also some body strength exercises that he would practice during the week. Every week, client would come back to see David, and he would measure his body composition, looking at his muscle mass, with also visceral fat, and seeing how over time client had less and less fat in his body. He was losing weight and he had more and more muscles, healthy muscles in his body. And altogether, this was very motivating for the client. Our client was highly motivated for his treatment. So he went through several years of treatment at starts. And having a client who really is so motivated and keen to apply everything that we could help him with and teach him was also rewarding for us as clinicians. So all the several hours work one after another with the client, he was the one who actually, through all work that he's done, managed to improve his own health. So at the end of physical exercises, classes, client was really fit, and he was really ready then for trauma reprocessing. Then he was referred to Indira, our clinical psychologist and really experienced psychotherapist. And Indira was using eye movement desensitization and reprocessing therapy. Neurofeedback and behavioral activation prepared the client for physiologically for this last leg of his treatment that starts. All the work for nightmares and using exposure therapy or EMDR is a key to, or most frequently, what we see is helping clients to deal with nightmares. For this client, this couldn't be applied until his seizures were reduced, his arousal was much more tolerable, and also his nervous system was more stabilized. So nervous system was stabilized, physically he was fit, and then 13 sessions only of EMDR help clients deal with his intrusions, his nightmares and flashbacks. Indira explained to the client that nightmares and intrusions and flashbacks are brain's attempt to metabolize or process past traumatic events. And clients was guided to identify several particularly distressing images and memories that he was thinking about and that he was dreaming about, and to identify symptoms of intrusions that are affecting his sleep. And then through EMDR, or processing of trauma, he was guided to focus on these disturbing memories to help him process his traumatic experiences. After 13 sessions, and on track after 200 sessions of altogether treatment that starts, Mr. Alam was physically fit, he was socially engaged and free of his trauma-related symptoms. He was able to enjoy life with his family. Looking at Harvard Trauma Questionnaire, we could see significant decrease in his symptoms of PTSD from quite severe at the beginning, and he recovered at the end of his treatment. And also looking at anxiety and depression symptoms, we can also see that there was significant decrease in his symptoms of anxiety and depression that frequently we see together with PTSD. So what are then the messages that we would like you to take from this session? Refugee trauma are often complex and they require staged and multimodal interventions. Impact on the nervous system results from cumulative and often severe trauma, and also daily stress of resettlement. Sleep is one of the most affected functions, and treatment often requires multimodal approach for the best outcomes. Neurofeedback and body-focused interventions are valuable adjunct to psychotherapy as they effectively address trauma on physiological level. Preparation of the client for trauma processing is an important part of their treatment. Biopsychosocial model of care is a valuable approach to treatment of clients with chronic and complex trauma that is related to war, torture, and refugee experiences. That's all from me and my team tonight. So thank you for your attention.